Okay, thanks so much, everyone. What a great set of presentations you just made. And now it's your turn in the audience. If you have questions, please, please, please take a moment to jot them down, and some of our staff and board members hopefully can help us be the ushers to collect them. We did actually have one submitted as you were all taking your seats. So let me start with that. And that goes to, I think, Dr. Ted and maybe Melissa. So here's a question. If you have a sister with breast cancer and you're eligible for the BRCA gene test, would you be eligible for the BRCA gene test, or would you have to go pay for it privately? This person's applied for it well over a year ago and has had no response. What should they do?
All right. Well, that speaks to your level of risk for breast cancer, I guess. So having a sibling with a cancer obviously puts you at an increased risk. In terms of the BRCA test, that is a hereditary cancer. And as Dr. Bax told me earlier when we were discussing this kind of thing, cancer is very common. It's very common to have relatives with cancer, but hereditary cancers are not common. So BRCA is not common. So just because you've had a sibling with cancer doesn't necessarily mean you need to be tested for BRCA. We have to know if your sister had BRCA in her genes, because it would have been tested when she had her cancer diagnosis. And if she did, then yes, absolutely, you would be eligible and you should be seeing the hereditary cancer program. If she did not have the BRCA gene or was not tested for it, then just the fact that you had a sibling with breast cancer doesn't necessarily make you eligible for that test. So what I would recommend in that scenario is to talk to a provider and go through the questionnaire about the hereditary cancer program. And if we know enough about your sister's diagnosis to make that call and she was BRCA positive, then yes, you should absolutely have that test. If not, you might not be eligible for having it done through the public system. But yes, you have that option to go pay privately for it, and that would definitely be faster.
Okay. What is the rationale behind aging out in the screening processes, e.g. colonoscopy and mammograms are not done over a certain age? Is it lifespan or cost or someone's really cranky or what? Thank you, Stuart.
So, we hear this a lot, and, I think this comes back to Ted's first talk. It's about population level risk. These screening programs have been designed around population level analysis, not individuals. Although you may age out of a screening test, does not mean you're not eligible to keep having screening tests done. It just won't be for the BC cancer normal screening pathways. So in those situations, I'd say it's well worth talking to your provider. Again, that's something we can support if you do not have a provider, but it's all about that. Then it comes back down to personal risk. It's not meant to be insulting. It's not meant to say you're not going to be living longer. We know lots of very, very healthy people in their 80s and 90s who absolutely a screening test. And I think here's the big thing. If you've got a screening test which actually has a positive result and it's going to lead to further testing, if you're fit to have those surgeries and that subsequent testing, then absolutely you should continue screening. When I would stop screening is when, for whatever reason, we expect you will not do very well if we do those further testings or do very well in those surgeries, for example. And that's when you might want to reconsider whether having unnecessary testing at that point going forward.
And I would just reiterate that a little bit more. The population level decisions and the giant list of criteria were designed on how to catch people in their time when they're at risk and they would be healthy enough to have, usually for cancer, it's a surgery to remove the cancer and then possibly going on to have a radiation or chemotherapy, which isn't easy on your body either. And the people, on average, when a lot of these screening programs were developed, were hitting 75 or 70 or whatever the age was. That was the turning point when the epidemiologists were looking at the data where it might not be feasible or the cost benefit of screening that population might not be worth it anymore. But as Dr. Back said, if you are fit and healthy and willing to do screening and you feel that you would go ahead and do those treatments if you picked up a cancer, you should still be screened. It just won't be through that formal BC Cancer program. It'll just be with your provider.
Here's one. My friend died earlier this month, 1 month after she was diagnosed with stage 4 pelvic cancer. She was very fit, never had any symptoms or illnesses prior. Is there any screening available for ovarian or pelvic cancer that you know of?
The pelvic we're usually talking about either ovarian or endometrial cancer for this. And that falls into that category, that slide of cancers that don't meet all of those criteria where a formal screening program would be feasible. And it's mostly because ovarian cancers in particular, they're very diverse in how they present and usually very vague. And there isn't a really good early latent stage because it kind of goes from 0 to 60. You either have no symptoms at all or you have lots of symptoms. And we don't have a lot of data on how long it would take between screening tests to pick that up that would be safe. The current evidence would be saying we should probably be doing an ultrasound of your ovaries every 6 months in order to pick it up in time to do something about it, which again is not cost effective. So unfortunately, where we are with the screening test, which is only imaging at this point, we don't have a screening test for it, and that's why we don't screen for it. You know, stay tuned. There's lots of money going into research about blood tests and biomarkers, but we don't have anything yet.
We have tons of questions, so if we don't get to them all, we will do our very best to have a summary of answers and available on our website. But let's keep going. What if screening mammogram shows a need for a diagnostic mammogram and it doesn't show anything? Diagnostic mammograms still see a 4-centimeter lymph node, but asked to go back to a 2-year screening. What happens to the lymph node? Nancy? Sorry.
So that sounds like a very specific situation. From a purely processes, if you have an abnormal screening mammogram, so this is when something is detected, it might be an asymmetry, it might be a little lump, you'll automatically get referred for a diagnostic. Diagnostics are generally more intensive, and they might do further testing and further modalities like an ultrasound scan. They might even do a biopsy at the same time as well. There's many ways the radiologist and the radiographer interpreting those results can tell if something it looks benign or sinister. So without knowing that case specifics, I would assume that it's being reviewed and it looks like a benign lymph node. However, the prerequisite would that's always worth having a discussion with your provider about as well. There's another aspect to this, and I suspect might be at play, and that's something called breast density, which a lot of you will hear about in the media and the news. It's quite a big topic at the moment. And that might change that recommendation slightly, because if there is proven dense breasts on that mammogram and that screening scan, that might also change your future screening recommendations as well. So, case-by-case basis certainly needs to be reviewed. The other thing which makes breast a bit more challenging is if there's any new lumps and then there's a negative mammogram, that should again always be seen in person. We will act upon sinister examinations even in the presence of normal tests. And this comes down to the fact that no test is 100%. We're playing averages, so any uncertainty always worth following up with the provider.
And I just add as well that, if you have a positive lymph node or a lump, that almost kicks you automatically into diagnostics instead of screening. So we should be following a diagnostic pathway, and you should talk to your provider more about what that means for you.
What options do I have if I don't have a family doctor and not have a family doctor? What annual tests should I be asking for?
Okay, so if you don't have a family doctor, you have, broadly speaking, walk-in clinics, UPCCs, which are the urgent primary care clinics, some of the telephone medical services such as TELUS and TIA. We are dedicated to cancer right now, but we're hopefully going to be doing some work on preventative medicine down the road, but currently cancer orientated. And those There's no annual test per se, unless you've got a strong family history, in which case there might be an annual mammogram, for example. Each screening test has their own criteria, and it will depend how those screening tests are and those results, which dictate where you're going down on that screening pathway. But generally speaking, you're looking at for an average risk person, every 2 years for a mammogram, every 2 years for a FIT test, every year for a lung cancer screening if you are deemed to have high risk for lung cancer, and 3 to 5 years depending on where you fall into the PAP or HPV screening pathways. There's no annual blood tests which are actually recommended from a cancer screening standpoint. Depending on personal history, there might be some screening blood tests for other metabolic illnesses like diabetes, but again, that would be something to have a case-by-case personal conversation with your provider or one of those options for those unattached patients.
Great, thank you. I read in the news that there is a lung cancer vaccine now in human trials. Do you know anything about how it works, and is there any possibility that this will be applied to other cancer types in the future? If you had a crystal ball, you should really tell us now.
I don't know how it works. I know that there's a lot of research in this area right now. And vaccinations for cancer is a huge, big area of research. And so I do believe this will be coming down the system. I do believe other cancers it will be prevalent for. HPV is a great example of that. HPV, we know, the reason we do HPV screening for cervical cancer is it accounts for almost all cervical cancer cases. It's also an incredibly common virus. And since we've been vaccinating our younger population, which has been happening around the world for many, many years, and in Canada relatively recently, we're going to see those cancer rates plummet as well. We also know HPV affects other types of cancers as well, so we're expecting to see those rates be affected, but we don't have that data yet. This is where time helps us. These epidemiological studies we talked about, and Ted talked about in the first part of this talk, we need that information still, and we're gathering it. But we certainly believe that the medical profession, we are aware that there's an interplay with viruses, for example, and this is where vaccines might become very important in this front.
Melissa, what's the difference between the hereditary cancer program and genetic screening, and how does a patient go about accessing the hereditary cancer program if indeed they have a primary relative?
Now, that's a really great question. So the hereditary cancer program, so just going back to the screening program specifically, the BC Cancer would recommend to the provider to refer a patient to the hereditary cancer program if their breast or colon screening came back or the results showed that a recommendation to that program would be ideal or recommended. And I'll have to admit that the hereditary cancer program is still fairly new. So I'm not entirely sure in terms of like the different types of services or testing that they offer, but I would imagine that genetic testing would be part of that work, depending on why you're being referred to their program.
I can speak to that a little bit. I've had a few patients go down that pathway. And yes, genetic testing will be included in that pathway. The hereditary program is very busy. They have got quite a wait time to be seen by them. The first thing above all else, though, is identifying the true risk. And there's only certain, again, cancers they can investigate. And part of that is a family tree, which they'll ask for at the very beginning. And it might be when they look at that, actually won't go all the way down for the genetic testing part of that test. So again, that personal history becomes more important. And there's a referral sheet to go through with your provider, basically, which might screen you in or out of that hereditary program and deem it whether it's deemed to be necessary going forward as well. One of the big criteria, which was alluded to in the earlier question about the high-risk breast genes, is testing the person who has the cancer is often the first port of call, because if they don't have the genes and actually it was just random mutation, random luck, then there will be no need to go down that hereditary program, for example.
Dr. Cricken, you've been doing some legwork here in Sechelt with the Cowrie Medical Clinic. Can you walk everyone through sort of how does an unattached patient get access to cancer screening if they want to go in the in-person route?
All right. So if you want to do the in-person, not the DIY route for cancer screening, then you're going to need to speak to a provider. And on the coast, I know that's really difficult, but there are access points. The Calgary Medical Clinic, where I work, the Gibson's Medical Clinic operate walk-in clinics that are for any unattached patients. If you draw the lottery ticket and get your phone call through at the right time, you can get in and see a provider there. The other clinics on the coast, they are all to some degrees booking same-day appointments for unattached patients. They're just not quite as big and don't have as much dedicated time. But you can also try the other clinics. They can sometimes get you in. That includes Pender Harbor and Arbutus and Upstream. Those are all clinics with doctors that have pledged to do some same-day appointments, but it's just not quite as established as Calgary or Gibson's. You can access the CanScreen clinic virtually, or any of the other virtual clinics like TELUS, etc., and they can get you started. And they will often kind of talk to you, take your history, and see what your risk is, or if you have symptoms, and see if you definitely do need to be seen in person, and then they can arrange that. And I'm not sure if Dr. Bax talked about it, but CanScreen has a network of doctors that they can get in touch with if you need to be seen in person for some kind of in-person exam. They can set that up, and we have providers on the coast who have agreed to do that. So if you go through a CanScreen route and you need to be seen in person, they can get a hold of one of us who has agreed to do that test. So that's where I would start if you want to be seen in person, is somewhere. If there is, again, screening-wise, we're talking about no symptoms. So you're, from a cancer point of view, feeling fine, you don't have any symptoms, then it's not urgent. I would not recommend going to emergency for that, because you're going to wait a long time, and you might have a doctor that says, well, you don't have symptoms. What are you doing here? I can't order your mammogram. I'm not going to follow up on it, etc. If you do have symptoms and you're worried, then that is an access point if you can't get anyone else. But again, screening, you don't have symptoms, you don't need emergency, but you have those other options that you can try. And then obviously I recommend everybody put their name on the health registry, because as we're hopefully adding more doctors to the coast, we can get everybody attached eventually.
Excellent.
I'll just add for cervix specifically, if you want to get a pap test, if you go to screeningbc.ca/cervix, we have a pap test clinic locator. So these are clinics that have told the screening program that, hey, we're okay with offering pap tests at our clinics to patients. So you can look that up and see all the different clinics across BC that you can reach out to for pap tests.
And we do have some nurse practitioners that are doing this through the health units in Gibson's and Sechelt as well for pap tests. So if that's what you want or need for your screening, then you can get access to that without a doctor.
On the pap test, you actually helped get me to another question here. If someone is 73 years old and they have a concern about a family history with ovarian cancer, should they still do a pap test?
So ovarian cancer and pap tests, unfortunately, are not connected. Pap tests are all about the cervix, which is a different organ than the ovaries. And so if you're 73 and you still want to have screening done for your cervix, you are absolutely welcome to do that. If you would be willing to have surgery and or treatment for cervical cancer and you want to keep on top of that, you go for it. You can get that screening through any of the providers we just talked about or your primary care provider. Ovarian cancer, we don't screen for because, as I mentioned earlier, we don't have a good screen test for it, and we have very little treatment for it as well. They're unfortunately not connected. Just because you've had a pap test or a pap screening or HPV screening for cervical cancer, that won't tell us really anything about ovarian cancer.
So there's a bit of marketing in the general public about some of the paid tests that are available. And I know, Ted, when we were rehearsing, we were talking about the advent of the full body MRI and how that might be a bit of a challenge to some of our physicians. He's smiling at least. Could you say a bit more about those paid tests that are currently available and being very aggressively marketed to the world? And as well, while you're at it, then can you talk about the relevance of 23andMe and what you do with all this information all of a sudden and all this technology?
So generally speaking, I would advise against them. Pretty simply because they pick up things which we don't know what to do with, or they're going to lead to investigations which are going to cause you potentially have their own risk of complications as well. These screening tests we talked about today all got a good evidence base behind them now. We know they're effective. I had a patient come in who's had one of these full body MRIs. We found something on their kidney. We can't tell by the scan what it is. We can't tell by a second scan what it is. They have to go and have a biopsy. They have the biopsy. They have a rare complication to that biopsy and a big bleed, and they lost their kidney. When we actually got the histology back, which is the microscopy test of this thing we saw in the kidney, it was normal. There was nothing wrong at all. So this is an example where, and I'm saying that's a rare, but it's a true risk of having any investigation. There's always complications and always risks. So then the question is, why do you want to have this test? In a perfect world, great. We're getting in a shower every morning, have a full body scan. We don't even know it's happened. It gives us our readout. And that's the future. Maybe in 200 years, maybe 500 years, that would be great, but we can't do that right now. So I come back to, why do we want this test? Am I worried about ovarian cancer, for example? Okay, so yes, an MRI might pick that up, but then how often do I get it? We know ovarian cancer generally is incredibly aggressive, which is what makes it so challenging. The reason lung cancer and the reason colon cancer and breast cancer is so easily screened is that actually those tumors tend to grow relatively slowly. Colon in particular will grow over several years. We've got time to pick it up. But ovarian or pancreatic is the other one I hear about a lot. Very aggressive cancers, they can grow very quickly. So do we scan every week? Do you have that MRI scan every 2 weeks, every 2 months, you've got to level that anxiety you have about possibly having a rare condition versus the anxiety from having a scan every 6 or 7 months.
Ghost.
I'm not doing anything. Yeah.
I think you've kind of summed up the main points of it, is that, knowledge is power, except sometimes it's not. Sometimes you don't know what to do with so much information. And especially the things like the full genome tests and that tells you, oh, you have all of these things that are associated with cancers or conditions. There's no studies actually yet showing that knowing that and acting on that prevents any disease. There's lots of studies showing that knowing that and investigating that causes harm. So it's, again, a question. Do you just want to know? Do you want to act on it if you have this knowledge? And in which case, what are you going to do? How are you going to act on it? Because as medical providers, we don't actually have that knowledge on what to do about a lot of these genes that show up. We can say, oh, yeah, sure, that looks like a lot of those genes are associated with cancer, but we don't have a screening test for that. And I would go back to my giant list of Wilson and Youngner's criteria. Is there a latent phase in this cancer? Is there a test for it? Is there a treatment for it? And just because you have the genes that are associated with it doesn't mean you are going to get it ever. So those tests are they're interesting. A lot of people like to go and do them. Particularly a lot of people when they, go down south for the winter and, in between golf games, they need something else to do. So they go to the local full body MRI clinic. Then they come back to our public system and say, I need to check all this stuff out. And you're like, well, we actually don't check for that. And we don't have evidence to say it needs to be treated. So those tests, they're lots of knowledge, but they're not actually always power.
Okay, I'm getting the hook. Thank you, Sarah. Thank you, panel, very much. And Joanna had one closing question for you, a stumper from the crowd. And that in summary, while everyone's filling out their surveys and their feedback, we'll ask that maybe some of our ushers could collect those. Could our speakers just make one last conclusive statement on why screening, including self-screening, why is it such an important tool to advocate for your own health?
So the screening is precisely to nip something in the bud. It's earlier to know about, or it's better to know about it earlier, so we can give you less treatment or less invasive treatment or a better chance of curing it than it is to find it later and try and deal with the consequences later. So it's all about being proactive and staying ahead of the game.
Well, I don't know how to follow that because that's exactly it, right? And I think we've heard questions today about, oh, should I do this? Should I do that? But here we have, on behalf of BC Cancer, 4 screening programs that have shown to be effective, that have shown to be helpful, that has shown to save lives. So if this is a way for you to actually be able to do that and change history, as as Christina had said in her story, then why not do it? So yeah, I guess that would be our takeaway.
Yeah, and I think to add to that, we're very lucky to have these tests available to us, and I think self-advocacy is really, really important. In a time when the healthcare system's being challenged and pressurized, in a time when many of us don't have family doctors looking after us, it's up to us to take interest in our own health. It's up to us to take responsibility for our health and seek out these tests as well. So yeah, that's where I really say, advocating for yourself is really, really important.